Okay, well, good afternoon, everyone. Well, I think it's about 1 minute afternoon, so that's correct. And welcome to our DFWBGH Corporate Benefits Forum. We present these forums for just our employers only periodically throughout the year on specific topics. And today's topic is a really important one. It's about obesity's linked to severe COVID-19. That's everything and everyone is. That's our focus, COVID-19. But this one's about the obesity's link and why it matters to employers. In the early days of the pandemic, doctors noticed something about people who were severely ill from COVID-19, and many of them were obese. Well, that was interesting. That doesn't get rated or counted in most cases on a cause or a contributing factor to death, or severe illness, but that is in fact what they noticed. And the excess weight increases chances of developing a number of health problems, including heart disease and diabetes and musculoskeletal problems as well. And of course, that increases the risk for COVID-19 or the severity of risk for COVID-19 as well. But then there's some evidence that obesity itself can increase the likelihood of serious complications from the coronavirus infection. And they're studying it, the researchers are studying it, trying to figure out why or what's the connection. But one of the things they found is that the virus infects cells by attaching to receptors on the surface of certain cells, and the receptor is abundant on fat cells. So obesity is a chronic condition that employers have been focused on and working on continuously. It's a public health challenge and is not going away quickly. We have 42% of Americans are considered obese. The Hispanic population and the African American population has a much higher percentage. And it's really important for employers to focus on that because it relates to so many of the other conditions that, that employees are subjected to. So that's what we're going to talk about today. And I'll introduce our speakers in just a minute, but we have a public service announcement we'd like to show. It's put together by the Creative Coalition and sponsored by Novo Nordisk, because Novo Nordisk is our sponsor for today's Corporate Benefits Forum. So let's take a look at this just to kind of set the stage for what we're about to talk about.
Hey.
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 So here's a little more bad news about coronavirus.
Excess body weight can make getting COVID-19 even more serious.
More serious.
Like increasing your risk of hospitalization
And severe illness. It's scary.
Scary.
Get the facts on COVID and obesity.
COVID and obesity. Look.
4 out of 10 Americans live with obesity.
So if that's you or someone you know,
you're not alone.
You are not alone.
The hopeful news is that we're all in this together.
Together.
And help is out there.
help is out there.
So take extra care.
Check in with a healthcare provider.
And find out what you can do to protect your health.
It could save your life.
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 That's great. So that sets the stage for what we're going to talk about today. And I'm very pleased to introduce our speakers who will be discussing obesity and the relationship to severe COVID-19 and why it's important to employers. Christian Moreno is our moderator for today's discussion with our other speakers, whom I'll introduce in just a moment. Christian is an expert in health and welfare plans for mid-size and large-size employers. He's the Senior Vice President with Lockton Dunning Benefits and has more than 20 years of international and domestic healthcare and industry experience. He delivers a nuanced message tailored to finance and HR executives across the U.S. He's a dynamic and compelling speaker. We know that. We've heard you speak before in some other meetings, Christian. He shares his knowledge related to healthcare financing, payer mix, and employer-sponsored health plans. He promotes understanding for audiences with diverse backgrounds and varying levels of experience. Christian will moderate the discussion, and Jason Lurk will be our first speaker. He is a medical accounts associate director at Novo Nordisk, a leading global healthcare company founded in 1923 and headquartered in Denmark. And Jason is headquartered in St. Louis, I learned today. Jason currently supports large employer groups, employer coalitions, including Dallas-Fort Worth Business Group on Health, and benefits consultants to ensure comprehensive understanding of diabetes and obesity and the clinical information as it relates to the health, well-being, and productivity of employees and their dependents. Jason will be followed by Dr. Tonya Yi Vinton. Dr. Vinton is double board certified in internal medicine and obesity medicine. She currently is the medical director for the Nutrition and Weight Management Program at Baylor University Medical Center of Dallas, and she also serves as president and founder of the Dallas Obesity Society. Following Dr. Vinton will be one of our favorite employer speakers, who is always willing to share her expertise, Rita White-Ross. She is a registered nurse. She serves as a dedicated health advocate for the city of Garland. For its employees and dependents, she's been doing this since 2011. And in this role, Rita provides classes, one-on-one coaching on wellness and disease prevention. She works closely with staff on employee health issues. She develops health improvement goals and objectives and acts as a resource for employees on all health and wellness issues. And Rita enjoys empowering others to take control of their health and well-being. Her personal mantra that she really shares with and throughout all of her work is, through your ability to choose, you create your own possibilities. With that, let me turn the discussion over to Christian, and who will lead off. And you all can ask questions in the Q&A box. You also please put comments and share information in the chat box. We look forward to working with your questions and fielding them with our speakers after their presentations. Christian?
No, thank you, Marianne. Thank you. I wish I could see everyone so you could nod if you can hear me, but I'm assuming you can. So I first want to thank Novo Nordisk as well as Marianne Faison and the team at DFW Business Group on Health for allowing me to come and speak to you all today. Full disclosure, I am neither an expert in COVID nor an expert in obesity as it relates to the clinical science behind it. I have kind of a bizarre and maybe somewhat unique background. I worked at the intersection of actuarial science and wellness in the first 10 years or so of my career. And so after joining Lockton, from time to time, I still get asked to come give my opinion as to how I see the treatment of and the lens through which employer health plans deal with obesity, particularly as it relates to wellness programming and any and all of the new and evolving treatments, as well as how we understand the disease. The science is evolving constantly. I would say we're going to spend the bulk of my few minutes with you talking about the lens through which we should be seeing obesity from an employer health standpoint. And since the anecdotal, although preliminary, science around COVID and its link in severity to obesity is probably more something that Dr. Fenton will talk about, I will comment that from an employer health plan perspective, this could have implications for the foreseeable future, not only given the health concerns for the employees, but also the costs to the medical plan. We'll frame it in that lens and talk through just a little bit around the science and the prism and the lens through which employers and the health plans probably need to look at obesity today. We can go to the next slide. The disease, as we understood it when I spent about 5 or 6 years at the Cooper Clinic, the disease itself was thought to be almost purely societal and behavioral. It was thought to be where you grew up, what habits you had. The science evolved since then to bring in just enormous amounts of data around the genetic makeup, as well as the biological influences that this disease, the contributors to it. And so we look at this as much more of a holistic and all-encompassing disease with multiple inputs, not just your eating habits, but rather what drives them and the decisions that we make around food. It's often, at least it was for a time, obesity was compared to, from a public health standpoint, how we attacked smoking. Why, if we were so successful in tobacco usage over time, can we not do the same here? Well, these 4 inputs highlight the difference and why that analogy may not be apropos. If you think about food and the decisions that we make in all of these inputs, we make decisions around that anywhere between 5 to 7 times a day. With smoking, you don't have to smoke to live. With eating, you do. When you look at all of these inputs, it's very apparent. We'll hear from some of our experts that this is just a much more complex disease, and the mosaic of risk factors that it presents can be costly, not only from a lost health and welfare standpoint, but also the medical costs to the plan. And so I think as you look at an employer health plan and any wellness or well-being program, which we're hearing more about well-being now than we maybe ever have from a mental health standpoint, is how does the employer health plan attack from all of these areas? What can the employer health plan offer to assist the members in dealing with this? And go to the next slide. And I am still drinking coffee at 1 or something East Coast time, so I'm going to be up, I'm sure. If we look at what we now know in terms of the complexity of the disease, the number of systems that are involved in the making of the decision around food intake and regulation of the metabolism, energy expenditure, this is not only complex in terms of how we make food decisions, but imagine overlaying things like the behavioral components of this, the genetic components of this, and all the complexities of the decisions that we make around food and food supply and how our caloric intake makes us feel. But these are all the different systems that are affected, and on an input basis, that's a complex decision matrix. If you go to the next slide, what you'll find here, which I'm fascinated by, is just all the systems that are affected. Now, what Marianne was correct in saying is that the early evidence suggests a linkage between obesity and the severity of COVID-19, at least in terms of the length and duration of the disease, but it's preliminary, and I would argue, although I'm not a clinician or a statistician, it's anecdotal. What more than likely isn't anecdotal is that the lag indicators to obesity, the clinical risk factors that come as a function of obesity, certainly can complicate the inflammatory response around COVID. That much is clear, meaning that the comorbidities often associated with and caused by obesity are clearly associated with the more complex and long-term recovery at this point. And so we're beginning to see the data shape out, but the causal or any causal effect between obesity and the severity of COVID has yet to be established. But I do think it's important to understand from an employee and employer health plan standpoint that when we look at 2021 into 2022, whether or not we have therapeutics or a vaccine, if we had a population where there were a significant amount of individuals with metabolic syndrome, would we, from an actuarial standpoint, make the recommendation to club differently for the cost? More than likely we would. And so it's within that lens that we want to talk with our experts today around what can we do to attack obesity, either through its lag indicators and its the metabolic syndrome, the comorbidities, but also attack what are the options ahead of us to be able to treat varying levels of obesity severity as measured by BMI or comorbidities. Next slide. And so I'll leave you with this as we look at, if we were just to take Wellness Program 101. 10 years ago, we didn't have pharmacotherapy as an option. All we had was either the big cut, bariatric surgery, which would be for your most severe. And then we'd come to you and say, if you can get everybody to exercise and diet, we'll be fine. Anybody with a BMI of greater than 25, but not too much greater than 27. Yeah, we would tell you that the employees needed to exercise more. We would offer wellness programming that said, we'll issue points for activities. But where we were lacking was the AOM and pharmacotherapy treatment. That's evolved a lot over the last 5 to 7 years. And the self-insured medical plan that wants to say, I need those individuals with a BMI of greater than 27 with comorbidities or greater than 30 to lose 3 to 9% of their weight loss, the pharmacotherapy option has become readily adopted by both clinicians as well as employer-sponsored medical plans. And so the advent of that pharmacotherapy treatment is really where we see most of the energy around that mid-tier weight loss, because in order to reduce the medical costs associated with obesity, anywhere between 5 to 10% weight loss sustained is necessary to really drop the healthcare costs and reach what we would term, which I'm always cautious about using this ROI number. It can be manipulated. And I'll say, when the studies take a look at real cost savings, or put another way, cost avoidance, it's clear that anything in excess of 8-10% sustained over time, you see a range of between $150 to $185 per member per month over time. And that's a significant component of medical trend going forward. It's not the big cost vibrations we see in the stop loss world and the large shock claims with cancer drugs and genomics, but it certainly is the frictional costs between $5,000 and $20,000 per member per year. And so the gap that if I were running my own employer-sponsored health plan today, where I would focus is that level 2. So the attacking of the mid-tier, or let's call it transient, individuals who may be on their way to either side, working with a clinician, assigning the physicians to treat obesity in the DFW marketplace and use all tools and resources, and then provide incentive structures within the wellness program to achieve those objectives. And so with that, I'll hand back over to our next speaker, Jason Lurk. If you're there and off mute, I will hand over to you and be here for questions.
Sounds great, Christian. Thank you so much. You know, I wanted to take a deeper dive in a matter of 10 minutes, which is a tall task at hand, but to build upon what Christian talked about and really go deeper in understanding obesity as a chronic and a complex disease. And I think just if we can take a second and think about whether we know someone that struggles with obesity, it may be a family member, a friend, a coworker. I think we can all relate to an individual out there who has excess weight, has maybe tried diet programs and failed and regained that weight, and think about the trials and tribulations that they've had over the years. So as we go into my next slide, please, I want you guys to imagine this disease affecting 650 million adults globally. And it's estimated by the year 2030, roughly 1 billion. There on the middle left, 2.8 million deaths annually. It is the 5th leading cause of global death. And imagine this disease that is chronic, progressive, associated with relapse, and affected by our own genetic makeup, our own hormones, which we're going to hear a little bit more from Dr. Benton, and our surrounding living environment. Oftentimes, on the top right, there's limited coverage for treatment and patients to receive treatment. Only about 2% of people eligible for pharmacotherapy or medications actually receive it, and the same holds true for bariatric surgery. And honestly, students, new medical residents, they're not adequately prepared to manage and treat obesity graduating from medical school. And oftentimes there's limited reimbursement for providing care on the provider side. So this is the current state of obesity. Next slide, please. And as we take that deeper dive into obesity, advance to the next slide, please. It's not simply a problem of lifestyle. It has its own pathophysiology, its own human biology. If we see here are 5 health-related organizations, agencies, professional societies that recognize obesity as a global health challenge, requiring a chronic disease management model. If you Google obesity, there's actually, if you Google obesity, There's 159 million hits in less than a second. And weight loss, 2.7 trillion. If you Google obesity, it states what the World Health Organization says there from a definition. It is a chronic disease. Interesting point, the year 2000 was when the World Health Organization recognized and said obesity is a chronic disease. See here the American Medical Association, the Food and Drug Administration, American Association of Clinical Endocrinologists on the top right, stating obesity is a primary disease, and the full force of our medical knowledge should be brought on to bear the prevention and treatment of obesity as a primary disease. So next slide. Unfortunately, what we know about obesity, or excuse me, fortunately, what we know about obesity isn't what we used to think of it. We used to think on the middle of the screen that our historical view of obesity, energy imbalance, was led by poor patient choices. If you look at the left side of the screen, these are words we don't want described because there is a definite stigma and bias, whether it's in society, in the workplace, in the healthcare setting, around obesity. A lot of times these words are thrown around. If you see them on the left, they're kind of faded but lazy, no willpower, no discipline, gluttonous, unattractive, less intelligent. Unfortunately, those are not poor patient choices. And now we're better understanding this modern view of obesity, the brain chemistry that I'll go a little deeper in what Christian said in his introduction, and how biology plays into our eating behaviors. We also know not all calories are alike. And finally, there at the bottom, psychological factors that will drive weight regain after weight loss through dieting. I talked about at the beginning, think of someone you may know that lost weight and gained it back. The body is making adaptations to that weight loss, resisting that weight loss, basically fighting against what that person had just done by losing weight. So how do we kind of block those adaptations as well? Next slide. As Christian said, and I'm going to go just a little deeper, but the brain is central in regulating appetite. I tried to simplify it as much as possible on the slide in kind of 3 sections. We either eat for hunger, behavioral eating or deciding when to eat, or on the far right, eating for pleasure. Let's focus on the far left or top left, eating for hunger for a second. This section of the brain, these hormones released endogenous, these hormones released in your body, ghrelin is released and tells the body, hey, I'm hungry, I need to eat. On the flip side, in response to food or after eating on the left, we have hormones that are released that tell the body we're full. That's where, from a medication standpoint, can we mimic or create medications that will enhance the feeling of fullness? There listed are a couple hormones, GLP-1, PYY, PPP, amylin, that are naturally occurring hormones that stimulate the brain to tell the brain you're full, it's time to stop eating. Next slide, please. As Christian said, and I have a very similar slide to his, but I do want to reiterate from the complexity of obesity. There are multiple complications associated with obesity, and actually just some are listed on my slide. There are other ones out there, but this is broken out into mental, mechanical, and metabolic. So if we think mental, depression, anxiety are at increased prevalence and associated with patients who have obesity versus the normal weight population. From a mechanical standpoint, sleep apnea, asthma from an asthma exacerbation standpoint, chronic back pain, incontinence, knee osteoarthritis, and then kind of in the darker color, the metabolic components of cardiovascular disease, type 2 diabetes, pre-diabetes. I think the point made here, I want to make is, we do a phenomenal job as a medical society, a medical community of treating these complications, but can we focus in on and do a better job of treating obesity as a disease state and not the complications that are most likely associated with it? can we treat that central hub of obesity and put a little more focus on it? There are, on the middle of the slide, 13 cancers that are at an increased prevalence in people who struggle with obesity versus a normal weight population. So next slide, please. And I definitely have to admit, Christian kind of brought it up a little bit, but a BMI or body mass index over 30 increases your risk of severe illness from COVID-19. Independent risk factor has been identified as obesity. If you look there on my graph, people from the age of 18 to 49, 63% risk of hospitalization if they get COVID-19 and have obesity. That's the highest group there that you wouldn't think would be at the highest risk for hospitalization. But there's data coming out, increased risk of hospitalization, possible increased ICU admission, and there's some data looking at mortality in the people who have obesity and contract COVID-19 due to obesity. Next slide. So I mentioned in the year 2000, the World Health Organization described obesity as being a chronic disease. If we look at where we've been from the year 2000 to where we are today, roughly 30% back in the year of 2000, 30% of the US adult population had obesity. Now we're upwards of 43, 44%. And then the bottom part in the red, I think the thing that we should maybe look a little closer on, severe obesity or BMIs over 40. A lot of times these are high cost claimants to an employer. This has doubled in the last 20 years, increasing at a rate higher than obesity as a whole. So more people are entering that BMI over 40 category or severe obesity. And next slide. So what do we do about it? What can we do about it from an employer perspective? And this is pigtailing on what we heard from the intro. Really, there's 3 treatment strategies, and they go hand in hand in my mind. Lifestyle modification might get you about 3 to 5% weight loss. We talked about the body maybe fighting to gain that weight back. That's where really pharmacotherapy may come into play or comes into play. In addition to lifestyle modification, can we get 5 to 15% weight loss? And your more invasive surgical procedures, gastric banding, sleeve, and gastric bypass, can get upwards of 30%. So next slide. Unfortunately, there are barriers to this chronic care model for treating obesity. And how do we remove some of these barriers? If we think of a patient with obesity at the top central of this slide, they're communicating with their provider, they're getting their benefits from the employer. The employer and providers really should be working with the payer to ensure that, again, weight loss surgery, pharmacotherapy, and lifestyle interventions from a benefit standpoint have alignment. Your lifestyle intervention, whether it's a diabetes prevention program or what have you, is aware that pharmacotherapy is a benefit post that lifestyle kind of 26-week program, and then as well as the surgical benefit as well. So next slide, please. And this is my final slide, but I just want to reiterate what impact obesity has from an employer perspective. It's known, and there's a lot of data out there. These are just a couple statistics, but healthcare costs are high. Obesity is associated with a 46% increase in inpatient costs, 27% increase in non-inpatient costs, and an 80% increase in prescription medication costs versus normal weight. From a productivity standpoint, costs there are concerning, whether it's absenteeism, presenteeism, disability, workers' compensation. And then finally on the right, the future of our workforce really is at risk. The people who are going to be entering the workforce the next 5 to 10 years, already 20% or 1/5 of individuals aged 12 to 19 have obesity. So again, the World Health Organization has declared this an epidemic, and I really appreciate the opportunity to discuss and take a deeper dive today and looking at obesity as a chronic and complex disease state, and maybe get the wheels turning about what we can do moving forward to help tackle and reverse that trend our trajectory of obesity continuing to increase. So thank you for your time. We'll be available for questions, and I'll turn it over to Dr. Vinton to hear from her.
Hello there. I'm Dr. Tanya Vinton. It's very nice to be here today. Again, I'm double board certified in internal medicine and obesity medicine, and I currently practice in Dallas with Baylor Scott and White. In 2009, I started a nonprofit organization called the Dallas Obesity Society, really to help improve education and engagement on obesity treatment for our DFW clinicians. So today I wanted to share with you really how much obesity is truly the epidemic that's growing and increasing the burden of disease on healthcare, and really brought to light this year with COVID-19. Next slide, please. So this is from the New England Journal of Medicine article from December of 2019. This was quite a shock, I would say, for the medical community when we saw these numbers. So on the left here, these are the prevalence rates for obesity. So BMI greater than 30 currently in 2020. And as we see how much it's going to increase in just 10 years. So what they anticipate, what we're projecting, is nearly 50% of Americans will have a BMI greater than 30 in 10 years. And if you see there, Texas is way over the 50%. On the right side, we have BMI greater than 35. So projected nearly 1 in 4 Americans will be in the severe obesity category in 10 years. Next slide. So high BMI is number 4 on this risk factors for health loss. Attributed deaths on the right side there. And as you can see, dietary risk is number 1, physical inactivity is number 5, and then multiples of the other things on this list are all actually obesity-related diseases. Next slide. This is from a slide from the OMA a few years back. So what are the costs of obesity? Well, direct healthcare costs estimated up to $200 billion per year. When we look at weight loss gimmicks, $60 billion industry. The cost of missed work days related to obesity, probably billions of dollars more. Also very unfortunate is that for those patients that really work on weight loss, unfortunately, only 15% of those can actually lose weight and keep it off. And that's really kind of been a sustained number over the past 20 years. Commercial diets. It's very expensive to lose weight, $750 to $1,250 per pound to lose and keep it off. So truly, we are spending a lot of money and not seemingly getting very far the way that we've approached it thus far. Next slide. So as we've seen during this COVID-19 pandemic, obesity is truly a significant risk factor for severe disease in our younger patient. And this chart is from an article from Lancet in May of 2020. They looked at the correlation between BMI and age in patients with COVID-19 admitted to ICUs at Johns Hopkins, University of Cincinnati, NYU, University of Washington, Florida Health, and University of Pennsylvania. So of the 265 patients that they looked at, they saw this inverse correlation between age and BMI, in which basically younger patients admitted to the hospital were definitely more likely to be obese. Also to say, in April 2020 from a JAMA article, they looked at comorbidities of 5,700 patients hospitalized in the New York City area with COVID-19. The top 3 most common comorbidities were hypertension, obesity, and diabetes. And of course, hypertension and diabetes are obesity-associated diseases. Next slide. So now that we have discussed the prevalence and severity of disease, let's really talk about what exactly is obesity. And this was on a previous slide. The American Medical Association defined obesity as its own distinct disease state in 2013, and that's really only 7 years ago. I like this definition from the OMA that describes obesity as a chronic, relapsing, multifactorial neurobehavioral disease wherein an increase in body fat promotes the adipose tissue dysfunction and abnormal fat mass physical forces resulting in adverse metabolic, biomechanical, and psychosocial health consequences. Recent studies have demonstrated that there are 236 medical diseases, I would say, and counting, that are associated with obesity. So truly, we're fighting a disease of abnormal hormonal balance and its consequences, and this is not a matter of lack of willpower or determination or personality flaw. I tell patients all the time, it is not your fault. This is not your fault. Your fat tissue is making you sick and making you gain more fat. So this was also seen previously from Christian and Jason. So this is, again, some of the common medical diseases associated with obesity. And I show patients this frequently to say, hey, just because you only have maybe 1 or 2 of these, look how many more friends may be coming to the party if we don't do something very proactive soon. And also to say, if we don't treat the root cause, obesity, how are we going to improve the overall burden of medical diseases that we're seeing? Next slide. So why are the prevalence numbers and BMIs continuing to increase? Well, it may be that there's implicit obesity bias and stigma about like basically stemming from our healthcare system. Patients have complained that PCPs rarely talk to them about weight concerns. They get the impression that doctors just assume a person is overweight or obesity must have an unhealthy diet and not really doing much to improve their situation. Patients also note that their doctors often give them really banal advice, such as just eat less and move more. Completely ignoring the fact that this is a chronic hormonal disease and it's just not as simple as eat less, move more. Even worse, most doctors really believe that obesity is a failure while demonstrating this implicit Obesity Action Coalition. 69% of patients report that their physicians were a source of weight bias. 31% of nurses prefer not to treat obesity patients. Next slide. So what kind of doctors are trained to treat obesity? Well, an obesity medicine specialist. So obesity medicine is a subspecialty requiring additional medical education and even fellowship training and a board certification test. The top 5 specialties that is pursuing obesity medicine are internal medicine, such as myself, family practice, endocrinology, pediatrics, and OBGYN. This is a growing field, and unfortunately, I would say, as of 2020, we only have about 4,000 physicians in the US that's board certified in obesity medicine. In Dallas, there's only 21 physicians. So clearly the education is out there, but very few physicians are currently qualified and trained to appropriately treat obesity. Next slide. So I started this nonprofit organization, the Dallas Obesity Society, in May of 2019 to really help bridge this great gap between the severe growing burden of disease from obesity and this obvious lack of access to care. So clearly, if 50% of the population is projected to have obesity, we need all the clinicians possible out there fighting obesity daily. So I found 9 other very eager obesity mission specialists in the DFW area to join me on this mission to engage, educate, and empower the treatment of obesity. And it's really our hope one day soon that we will have all clinicians able and willing to counsel patients with some medically based interventions. So just as your emergency medicine doctor right now would discuss smoking cessation if you presented with emphysema exacerbation, we really should expect the same for obesity management. 2020 has been a challenge for everyone, including Dallas Obesity Society, but we have persevered, and we've actually been able to hold some virtual CME conferences this year. We did one on the pillars of obesity medicine and another one on bariatric surgery entitled Cut to the Chase. We've also done 5 free Zoom events for educational lectures for all those interested in participating. And our event last week actually included a physician from Hawaii and one from India. And the one that we're expecting tonight, we've got people all over the country. We've got people from Illinois to California, and plenty of those all over Texas joining us. So again, very excited about this opportunity to help engage more clinicians on the treatment of obesity and how to do it appropriately. Thank you so much for your attention, and I'm really, again, honored to be able to participate today. Thank you.
Rita,
pass it on to Rita.
Let's hear from you.
Yes. Next slide, please. Next slide. So as you can see, all our speakers basically on the same track. We have one of the same infographics. And a lot of times I go out in the field and speak to our employees. With the city of Garland, we're predominantly a male, And so one of the things I always share with them, if they're snoring or if their wife or someone tells them like, oh, you sound like a freight train, always encourage them to come in and be checked here at the clinic. Even I share with them that we don't do sleep studies, but that we can do weight management. So as you can see, obesity affects just about every major system in our body. Next slide. So now we're talking about some of the risk factors for obesity and COVID-19. Next slide, please. Uh-oh, my computer's about to, oh my God. Trying to get it to snooze. Let me get some help. So, just a minute, please.
It always seems like you want to restart right in the middle of a virtual.
I know. Can you snooze it, please? And so with obesity, you're in COVID-19, you're more likely to develop complications. So if you're obese or pregnant, advanced age, now that I'm past that age, I'm like, oh my. Race and ethnicity, and here at the City of Garland, we have a large Hispanic population, and so we're culturally diverse here in our workforce. And so I always try to make the information relevant to our employees, and that's why I like to go out in the field and encourage our employees to be as healthy as possible and bring them to the clinic so they can be treated. So I'm not sure if I can advance the next slide. Yes. Oh. Okay. Do you want to? Okay. Go ahead. Okay. Okay, some of the risk factors, again, are BMI. And so here at the City of Garland, our average BMI is 30.10. So we are in that obese category. So then it puts our employees for more at risk for complications of COVID-19. We've had 10 employees that have been hospitalized, and we're very fortunate we have no loss of life secondary to COVID or any complications of COVID. So some of the underlying conditions, and we have employees, quite a few employees that do have high blood pressure, diabetes. And so here at the clinic, we do a lot of hand holding. We have a diverse staff. We have a male medical doctor and a male nurse practitioner and 2 female nurse practitioners. And so our employees have a lot of options as to which provider they would like. And we closely follow our employees because there is no out-of-pocket for our employees to visit the clinic. Our diabetes medicines are covered at 100%, and also our obesity medications are covered.
You want to let me close this?
Okay, so I'll just go on to the next.
Yeah.
Okay, so this is our actually all of our employees. And so we're very fortunate that with our health plan, and our providers are quite aware of our benefits because we all have the same benefits. So there is no pre-auth for any medication. So that's fortunate. So we try to make it as easy on our employees to be able to access care and understand their benefits, and our staff are acutely aware of our benefits. We have an on-site lab, so we can do our lab work and testing right here on site, also on-site COVID testing. We do our own contract tracing, and so we know all the employees who may have been exposed. And also we work closely with the Garland Health Department. When we do our coaching, especially with obesity, we have to be very culturally sensitive because, like I said, we have a high minority population, and especially Hispanics and Blacks. A lot of times food is, and I know in the Black culture, they say if a man can't afford to feed his family, he shouldn't live. And so therefore everything kind of revolves around food, especially holidays. So with Thanksgiving coming up and Christmas, it's like a food fest. And with this COVID-19, they're saying, most people are gaining at least 15 pounds. So when you look at that with the COVID-15 and then Thanksgiving and Christmas coming up, someone could be like 30 pounds. So, oh my goodness, it's doing it again. Okay, so we respect the struggle because obesity is a serious medical condition. And so we do, like I said, we do a lot of whole handing and have our employees come back for frequent follow-up. If we need to assist them with injectable medications, we do that until they're comfortable. We also do depression screening because we know that a lot of times people who may be overweight or obese, they may also be suffering from depression. So that's very important. We do refer out to specialists. We try to do as many things that we can in-house, especially with obesity. When I go out in the field and talk about obesity and other conditions, and I try to tie it in to their lifestyle so they can understand that struggle is real, and that's why the clinic is here to help employ our employees to be as healthy as possible. We also do have like Naturally Slim and Livongo. Naturally Slim is a weight management type program. So most of our benefits are tied to things like diabetes and obesity. So therefore we have a lot of support from HR and our clinic staff. Again, we can do personalized obesity education. We have Livongo, which is a diabetes program, because as I've already said, a lot of people that have diabetes also are overweight. Let's see, are there any questions? Because I don't want my computer to die out.
thank you, Rita. Thank you, Dr. Benton. Thank you, Jason, and thank you, Christian. This has been a really scary discussion, hearing from all of you, the different perspectives. But I have to say, Rita, you have one of the most impressive, comprehensive programs that I've seen laid out for addressing obesity in your workplace. The services that you're offering are just remarkable. I think this would be almost like a playbook for other employers, those who are listening in. Just take a look at this laundry list of all the services that you're offering through your City Care Clinic. This is really impressive. One of the things that I think would be a good starting place for employers would be to think about one of the statistics, I think Jason, you gave back, that only 2% of the people who are obese or overweight are actually getting their medications to treat obesity. This sounds like a real big problem. In fact, the problem for treating obesity doesn't belong to any one group, not only to the employers, facilitating the coverage of obesity medications or treatment, and then even to the Christian, to your as a benefits consultant and even advising, working with the employers. This sounds like it's such a big issue and affects so many other conditions that employers are paying for, and employers are suffering through. It sounds like this has to be an all-out front from all the parties involved. So back to you, Rita. You asked, you mentioned all of these great things you're doing. It's really impressive. I imagine you're getting data, perhaps from Livongo, from Naturally Slim and some of the other people that you're dealing with, perhaps from your health plan. Are you getting data on the success of these programs? I mean, when you're looking at your employee population, you said that you have like average is 30 point something BMI.
Yeah, 30 points.
How are you seeing a lowering of the BMI on average?
Yes, on average, here, especially here at the clinic, because we follow our patients so closely. Because if we have them come back in 2 days, 1 day, 1 week, they can come back because they don't have that copay. And if you think about copay as being $30, $45, $50, a lot of times our employees, can't necessarily afford to come back in 1 week for another $50 and just get weighed. So therefore, that definitely increases our ability to lower our BMI.
Okay, good incentives there as well. So it's a very nicely aligned program. And I think the city of Garland is exceptionally fortunate to have someone like you overseeing all of this and really so totally engaged in working on all of these different aspects of managing obesity and all the other conditions that you have going on.
Yeah, we're fortunate to have a forward-thinking manager, because our regional manager is responsible for the clinic, and so our risk manager. So we're fortunate to have him, and he's the one who started our clinic. So we're very fortunate. That's
very good. Very good. That's why you're our poster child for things like this as our speaker. And we appreciate your sharing all of your information. I want to go to Dr. Benton. Wow, you really brought out some really powerful and scary information from the physician perspective, and I applaud you for starting the Obesity Society in Dallas. And I hope that it's totally successful in what you're able to do, especially with the physicians. The scary part to me, or maybe the question is, the physician's responsibility. Employers our employers, we've been are advocating and really beefing up their access to primary care as the first step before you get referred to a specialist and so on, because it's really in the primary care setting that so much can be taken care of before more specialty care is needed. What is the primary care physician's responsibility to addressing obesity? I get my weight, every time I go to the doctor, they take my weight. Well, I'm not overweight really, so I'm probably not a good example, but what happens? Are they addressing it? You said that they're so many of the physicians think that it's just fix it by diet, or maybe it's a psychological behavioral problem. Tell us about a little bit more of that, because we want to engage the primary care physicians.
I'm definitely on board with everyone needs to discuss this with their patients, especially I would say the primary care doctor. It has to start with your primary care physician. That's usually the person that you see the most throughout the year, right? Most unfortunately, though, is that your primary care physician is not well knowledged on what's going on. Like, they don't understand the disease process. They don't understand that it is the root cause for all these other issues. They don't understand that potentially they're prescribing medication that's worsening your metabolic rate to be slower, and then basically making you gain weight even faster. They also end up making the patients perhaps feel more uncomfortable about the situation, because when you broach the subject with them, your doctor may not be particularly sensitive about your efforts in trying to lose weight and trying to improve health. So a lot of this really has to be treated through, like, how do we improve our clinicians' understanding of the disease and then give them some basic tools. So I think that's really where, if we want to have our primary care doctors be the frontline folks to treat obesity, then we have to help them with some tools, with some basic education.
Yeah, for sure. And again, it's no one party's stakeholders' responsibility to manage all of this, certainly not on the employer's back, but we see things that City of Garland are doing, and many of our other companies are doing similar types of support for people who are obese or overweight. But we really have a challenge in getting to the primary care setting, and through what you're doing, Dr. Benton, we're trying to engage the physicians in a much more aggressive management of overweight and obesity. To you, Jason, I liked your chart in particular that showed what types of stages of treatment should be done for different stages of levels of the BMI. I thought that was really helpful, so that if, like Rita, who has found out or determined what the average obesity or BMI is among her employees, if an employer would do that and figure out what the average is, they might have a better handle on, would you say, in starting with medication, well, first of all, the diet and exercise, but then moving into the medications, and hopefully the last resort would be surgery. What's your thinking on that?
That's a good point. And something I didn't bring up that I normally do talk about is prevention and treatment. So a lot of times, if things come into play around prevention and putting preventative strategies in place. And really, prevention with obesity is preventing the overweight population from developing obesity or BMI of 30. The unfortunate thing is we have a 40+% population who has obesity, and really we need good, positive treatment strategies toward that population. So speaking specifically to the population with obesity and focusing in on treatment, to your point of those three modalities of lifestyle modification, making those behavioral changes, getting people or helping people lose maybe 3 to 5%. They will plateau at some point. That's where then most likely a medication may come into play for the right individuals. There's a couple of different medications out there, and understanding of how they work and how they may aid in the weight loss and keep the weight loss going by blocking some of the body's biology or mimicking the hormones and helping them lose weight. And then again, kind of those surgical options, you may see 20 to 30%. There's a population that surgery is indicated in. So really, I think the biggest thing from an employer perspective is understanding those three buckets or pillars, if you will, and ensuring benefit alignment, opening up opportunities for treatment of obesity with those 3 benefits, I guess. Does that kind of answer what you were thinking?
Yeah, it does. It's really helpful. And I think it's really helpful to the employers who are listening in today. Just to kind of, it helps to have that kind of a model of sorting of things, because otherwise it's just such a massive, mushy problem to deal with. So that definitely is helpful.
Sure.
Christian, we don't have a health plan representative on today's program, and I know you work a lot with the health plans and with employer clients, and I don't want to pick out anyone in particular, but what's your thinking about when I mentioned it sounds like we need to have all of the stakeholders engaged? What's your thinking of the role of you as an advisor to employers and almost maybe the mediator with the health plans?
That's a great question. It's a tough one to answer, Marianne. I'll say this. I think there's 2 dynamics at play when we talk to employer plan sponsors about how to deal with, mitigate, help address this issue. The first one is the broad-based PPO, take all comers. 90% of all physicians throughout the United States or the Metroplex that are included in those standard networks. Makes it difficult to treat and care for in a complex ecosystem of obesity management and treatment. So I think the fundamental PPO structure fights against what Dr. Benton was talking about, which is one of the issues that we see, right? That's 1. 2, the availability of data and the artificial intelligence associated with the obesity and incentive structure inside of wellness programs is a real problem. So it's got to be nuts that today I put all my exercise, my Fitbit, my Garmin watch, all that data, my biometric screening, it's all available inside my wellness program. How much data can my physician see of that? 0. So there's a disconnect in the supply side and demand side of healthcare that I think high performance networks, ACO, patient care, medical home, primary care quarterbacking will help solve. That might be more than you were looking for, but that really is my passion around when we talk to this about employers is you just can't boil the ocean inside of that large, expansive network.
So this is an all-out front that we're facing. Dr. Benton, in your opinion, would you think that if an employer, for example, or an organization were to tackle obesity, not just because of its severity with COVID, that in and of itself should make us really concerned and really going after obesity. But in your opinion, to all of these other associated conditions, the diabetes, the heart disease, the, back pain, the cancers, and so on, would you think that would be a wise place for employers to start their tackling this behemoth? Would you say obesity and overweight and obesity would take care of a lot of other things if we got that under control?
Absolutely. So if you guys like watching TED Talks, one of the big doctors that talks about obesity is Dr. Peter Attia. And I really like this analogy that I sometimes tell my patients. So basically, he's a surgeon. That's his background. And he says, if you came to me, you're the patient, you have this wound on your leg, got an ulcer. Sometimes it's this big, sometimes it's this big, but you just keep coming back. And every time you come back, I give you different bandages, I give you different salves, I give you different antibiotics. Again, it gets bigger, it gets smaller. You keep coming back. Sometimes you get more. I never ask you, hey, how did you get this wound? Why does it keep coming back? And it turns out that you go home and you knock your shin on this coffee table 50 times a day. Sometimes it's 100 times a day, never addressing that underlying problem. He says, basically, this is how we're treating our medical diseases. We don't treat the root cause. We're just putting different bandages on, and then we get frustrated when they fall off, and then we have to do more. But truly, when I discuss the treatment of obesity with my patients, this is not about how much weight you're losing. This is about how much health you're gaining. Because as you reach 5%, 10%, and then 10% plus weight loss, guess what happens with your blood pressure? It starts getting better. We can actually start decreasing your blood pressure medications. We can start decreasing your cholesterol medications. Most of the diabetics I work with can get off their insulin. This is like almost all of them. We can get them off insulin, which if you look at the cost savings on that alone over a lifetime, I mean, that's tremendous per patient, right? It's like $1 million usually, right? So just in one person, you're decreasing potential hospitalization risks, you're decreasing medication costs, and then eventually decreasing, how many times you have to go see your specialist, because as you get healthier, you have less risk of heart disease, your stroke disease risk comes down. A lot of my referrals now come from cancer doctors because they know that after you've had your cancer resected, you've finished chemotherapy, what is the most likely reason your cancer is going to recur? Obesity. So yes, if you don't want your cancer to return, you want to decrease the likelihood of recurrence, yes, we need to treat the root cause. So I think definitely, very clearly in my practice on a day-to-day basis, yes, we're actually able to reverse a lot of these diseases, get people off medications. Is definitely worthwhile pursuit.
Thank you. That's really helpful. There's another issue that we talked about the BMI, and that's kind of that's everybody measure what your average is in your employee population and how important that is. But that seems like a pretty gross type measure, speaking of obesity. You deal with obesity medications. Is that, and what we're not advocating, and I don't think you would advocate just starting immediately someone on medications. Can you tell us about how you decide whether a medication is the right thing or some other approach to helping a patient manage obesity? Dr. Benton.
Yes, great question. So it really needs to be a very individualized process. So a lot of what I do at the first visit is a very comprehensive history. So I need to know what's going on with your current medical diseases. Do you have hypertension? Do you have diabetes? What kind of history do you have with weight loss? Have you been going up and down for a long time? Because that really, worsens your metabolism if you do that. And then, some patients that I see, they've actually already had bariatric surgery. So all of these things have to be taken into account. Their current labs need to be taken into account because basically the degree of where your body is from a metabolic status, that's really what determines how aggressively we need to go at it. So for example, for those who have diabetes, they're definitely a lot more just physiologically resistant to losing weight and much more likely to regain. So those patients really have to start from day one some sort of anti-obesity medication, because if we
I think we lost your sound, Dr. Benton.
we don't, it's really really not going to see any results. Whereas if you have a patient that's not actually tried weight loss at all, and then we start making some adjustments, they can actually start improving, and we may not need to use medications.
Mm-hmm. Thank you. This is, we have just a couple minutes left. Are there any of our participants, employers particularly, who have any other questions that you want to ask whether Christian or Dr. Benton, Rita, or Jason? You can type it into the chat box or the Q&A box, and we'll make sure that your questions get answered. So, any other questions? While you're thinking up your questions, if you have any, I want to call your attention to a resource. It's an infographic that we put in the chat box that's available. I've got a few highlights about obesity and its connection to COVID and the severity of COVID. That's the important thing. But from today's discussion, COVID is critical, but that's not the reason. That's not the key reason why employers and physicians and everyone else involved in treating people, that's not the key reason we should be paying attention to this. It's important. It's another reason to pay attention to it. But it's such a massive problem at 42% obesity in our country, and then working adults who are obese, according to some of the charts we saw today, the number of working adults and those who are hospitalized from COVID, these are all reasons why we should be paying close attention to it. And it's not just one organization or one stakeholder, it's not the employer's responsibility, although the right coverage and so forth and programs that, like Rita described, are important. It's not just the physician's responsibility to treat this. It's not the benefits consultant or the health plan. It's all of our responsibility, and I think it's going to take an all-out battle plan for all of us to treat this. We are about out of time. I did not see any other questions in the chat box or Q&A. So I just want to take this minute to thank all of you, all of our speakers, Christian, Dr. Benton, Jason, and Rita. We're very, very pleased to have you. I want to thank Novo Nordisk for sponsoring this. It's been very informative. And the recording will be available to all of our attendees after, we'll send you a link for all of them, to all of our attendees today. And we'll also answer any other questions if you have any. We can field them to our speakers if you think of something afterwards. And I want to thank you again for participating in today's program for Dallas-Fort Worth Business Group and Health Corporate members. Thank you so much, all of you.
Everybody.
Bye now.